Well, thank you for having me back at the podium. I want to start with a story. I got a call from the husband of my daughter's piano teacher. It's now been a few years, but it's a call that stuck with me. He said that Peg is in the hospital. She'd been sick for a little while. I knew she had developed cancer several years ago, a soft tissue cancer in her pelvis called a rhabdomyosarcoma. She'd undergone a radical operation to remove a third of her pelvis and reconstruct it with metal, underwent radiation and chemotherapy. But with that, she became disease-free, a very good prognosis, returned to teaching, 3 years with the main side effect being that she had to walk now with those Canadian crutches that are the ones that wrap around your wrists as you walk around. There was, however, after about 3 years of this, signs that her blood counts were dropping, and she proved to have a side effect of her chemotherapy, a leukemia-like condition called myelodysplastic syndrome. This is essentially like a cancer that come back itself, and so now she had to start chemotherapy for that. She was adamant that she was going to keep teaching all the way through it, but her blood counts did not respond. She developed fevers and then ultimately was admitted to the hospital. And that was when her husband called. He put her on the speakerphone, and I asked her what was going on. She said that the treatment was not working, that her blood counts continued to drop, she continued to have fevers, she developed infections. They did scans to look and see where the infection was coming from. They couldn't quite find it, but they found that the original cancer had now come back as well. It was growing in another part of her hip. It was in her liver, and as time advanced, it became so painful, that bony involvement, that it became difficult for her to get out of bed. She developed incontinence, and now she'd been in the hospital for 2 weeks. And her question was, what should we do? And I think this is, in fact, the moment we debate, the moment we are all faced with as family members, as clinicians, as societies. What should we do? What do we want for her? What is a good outcome here? It is a condition she has that's incurable by any known means. So what she was asking is, there were doctors suggesting, well, there were unconventional options, experimental options. There are no known therapies, but maybe they should try to do a bone marrow transplant and high-dose chemotherapy as an option. Should they at least try something, anything, no matter what? Or should they, as she put it, just give up? They come to me saying, well, we could just keep you comfortable. She said, that didn't seem like much of anything to look forward to at all. And what I thought was, I've been in this situation, I've been in this conversation over and over and over again. And I felt utterly incompetent for having this conversation go well. What does it mean to handle these situations well, to come to a good place? Well, the one thing I knew was that the options, we should do something, anything, or do nothing, were the options that we typically discuss, but they don't seem like the real options that we have. And so my investigations, along the way, I wrote the book over a few years, and I found that a good answer was tied to a seemingly unrelated study. There's a Stanford professor named Laura Carstensen, and she had done a landmark series of studies tracking and studying the emotional lives of people as they age. She had followed several hundred people that at the beginning of the study were ages 18 to 94 when they began. And she would have them carry a beeper, and periodically she and her team would page them. And at that moment, they would ask them a question that they would record, and that's how they would gather information. The question might be, at this moment in time, what are you feeling? And there'd be a series of choices. Are you angry? Are you sad? Are you frustrated? Are you happy? Are you, name any of the above? Or it might be a trade-off question. If you had half an hour right now that you could do anything you wanted, would you rather be with your sister? Or would you rather be with the singer of your favorite song? Would you rather go home tonight for an evening in? Or would you rather go out to a nightclub shouting at the top of your lungs above the music, all in the hope that you might meet someone new? Well, what she found was that people gave very different answers, depending on their age. There was a young signature and old signature. The young signature was that people wanted enlarging social networks. They were trying to meet more and more people. They were trying to achieve more. It was an acquisitive kind of signature. You wanted to get and have and accumulate. You wanted visibility and recognition. But the older signature was that people wanted smaller groups of people to be connected to. They paired their social networks, but wanted deeper, more intimate relationships with those people. And they had very different emotions that they experienced. So although as they got older, they were definitely facing increased healthcare issues, poorer health, greater disability, loss of functions that they once had, they were happier. They were notably calmer. The 75-year-old had a lower likelihood of anxiety or depression than the 35-year-old. And they were also more satisfied to have the recognition of their own family and be connected to them. They could experience emotions that they hadn't, many young people don't even know, like the experience of poignancy, which is the ability to have a positive and a negative emotion together at the same time, that bittersweet kind of feeling. Well, that was to me an incredibly striking thing, this set of information. Because what it suggested was that, where we think of the whole goal of healthcare as improving people's well-being, we equated well-being with being healthy and independent. And yet you could see people who were becoming less healthy over time and becoming less dependent, who had well-being. In fact, sometimes better well-being than they did at a younger age. The well-being was possible under extremely severe circumstances. They had what you and I would, call wisdom, in a sense. And part of the puzzle of it, to me, was, why does it take so long? Why do you have to wait till you're 75, 85 to have it? And there have been theories, people have written about this, that maybe it takes practice. You have to have had experience before you recognize these kinds of values. Or maybe it is a structural thing in our brains, that our brains have to change, and it's a physical phenomenon that you can't experience those kinds of capabilities. But in the study, Laura Carstensen found that that was wrong, because there was a group of people in the study. It started in the late 80s, early 1990s, during the height of the AIDS epidemic in Northern California, where Stanford is situated. And there was a group of people in the study who developed HIV, and then their treatments were failing. They were becoming terminal. And the fascinating thing is that they went from the young signature, they could be 24 years old, and they went from the young signature to the old signature. They did not want to hang out with the singer of their favorite song. They wanted to be with their sister. They did not want to hang out at the nightclub at night shouting in the hope that they meet somebody. They wanted to be with family and be close to people that they loved. And they were also, interestingly, often had lower rates of anxiety and depression, felt more purposeful in their lives. And the experience of 9/11 then even made it starker, because in the middle of the study, the Twin Tower bombings happened, a great deal of uncertainty in people's lives entered, and the entire cohort shifted from the young signature to the older signature. People all wanted to be reconnected to their family, and they wanted to do something that mattered to the community as a whole and not just their own stuff. People actually felt a sense of being alive and very purposeful. And then 3 months later, they went back to the young signature and doing exactly the way they were doing things before. Well, this brought home to me the idea that what mattered in people's lives was a little contrary to the way that we think about it normally in medicine, and it had significant consequences. One of the things is that in people's lives today, you don't have to think about the fragility of your life very much at all. Public health plus the success of medical care has made it so that you can reach the age of 65, 70, 75 without ever having to be very aware that your life is at risk. That's very different from previous centuries. In the 19th century, 1900, the average age of death was 47. And it wasn't that there were no old people, there were some, but it was almost a random luck that you would make it to an old age. You were at risk of dying at almost any point in your life. You could die of a strep throat at age 13. You could die in childhood from a diarrheal infection. You could die in childbirth. You could die in a road traffic injury. A compound fracture would be enough to be a deadly event in people's lives. And so fragility was ever present, and people therefore understood that health was not the same as well-being. And in fact, it was not even necessarily the necessary condition. It was very helpful, but that people were aware they had priorities in their lives beyond just living longer. There was a great book I came across by a philosopher writing in 1908. His name was Josiah Royce, and he wrote on the philosophy of loyalty. He wanted to know why just being safe and well-fed and comfortable, just being alive, felt insufficient to people. And what he believed was that there was an intrinsic human need to live for something beyond yourself, to live for something larger than yourself. And he called that thing your loyalty. Your loyalty would be something you'd be willing to sacrifice your health or even your life for. And that could be your children, your family, could be your country, could be an ideal like justice, it could be God. And he contrasted that with the individualist view that we are all ultimately self-interested people. And he was arguing against the dominant economic view of the time, that at the end of the day, everybody, you just pay them enough and they're just selfish and they'll do what you want, you just have to pay them enough, and that's all it amounts to. But he ran through a series of thought experiments to help show that in fact we are willing to sacrifice our health in certain situations for ideas beyond health, for things beyond ourselves. And one example that I liked a lot was that he said, would you care about what happens to the world after you die? Suppose we told you that 1 hour after you die, that the world will explode, taking everybody you know in it with it. Does that matter to you? How many of you would that matter to you? It makes your life feel meaningless if there's nothing that goes on. And if your own desires and achievements were the only things that mattered in your life, then you wouldn't feel that way. But the fact that we do feel that way is incredibly relevant. And it is a relevance that comes home most when you are most frail, most ill, and we are kind of oblivious to it. Today, we mostly see in medicine, we see a good life as a life of independence and of health. And it therefore doesn't fit with a world where you're going to spend a significant amount of your life aging and frail, with infirmities that accumulate, that you'll spend significant parts of your life perhaps with a chronic illness, and some part of your life with even a terminal illness. Now, our medical focus is on survival, on your health, and that makes a certain amount of sense. But we end up being lost when that is not possible. And I think we've lost sight of the idea that well-being is more than your health and your safety and your survival. And the result is therefore suffering. We see it in our old age homes. For example, in the fact that people are told that you can't have a drink. Can't have a cocktail at the end of the day because it's not safe. Or that I described meeting an Alzheimer's patient, 85 years old, who's hoarding cookies because they have a medically prescribed diet that says they can only have pureed foods. I was giving this talk at a White House meeting, and one of the senior staff advisors of the president pulled me aside afterwards and confessed that she'd been sneaking bananas into her mother with Alzheimer's at a nursing home against the rules of the nursing home. Give them the damn banana. And even more than that, people are miserable in nursing homes. The common thing that you'll hear people say is, when do I get to go home? Home is where you get choices. Have some choice about the risks that you can take and not take, and also some ability to connect yourselves to those things. Remember we said when you get older that the thing that becomes very important is having deep connected relationships to others. And yet we often sever those ties. We bring you into a nursing home because you can't take care of yourself anymore, but that doesn't mean you can't maintain your friends. And why couldn't we sustain those connections? Allow you to keep going to the church or the synagogue or the religious establishment that you were part of instead of forcing you into the one that you were in. And I described my own wife's grandmother withering entirely because of losing all of those ties that were the sources of meaning and existence and dignity for her. Well, we also see it in the hospital. We see it in a case like Peg Batchelder, that piano teacher of my daughter's, lying in bed for 2 weeks in a hospital. And what she'd come to was a place where none of her caregivers had any imagination that a life worth living was possible for her anymore. In the course of the work that I did, I ended up interviewing about 200 patients and family members about their experiences with aging, their experiences with terminal illness, and also interviewed scores of people who see a lot of these folks, palliative care physicians, geriatricians, hospice nurses, nursing home aides, directors of nursing homes, all these unexpected people I've never really connected with before, and asked them what they do and how do they do it. But I found people who were exceptionally good at knowing what to do when someone like Peg or a patient, or as would happen later, my father, who developed a brain tumor, what to say to them when they call asking, what should I do? And the key thing that they pointed out was that we in medicine and society have failed to understand that people have priorities in their lives besides just living longer. They have loyalties. And those loyalties are quite different from one person to another, but they want us to serve them and help them preserve their capability to deliver on those loyalties, especially as they come to the end of their life. And then the key, if we want to know what those loyalties are, there is a highly technical procedure, sometimes difficult, to find out what those loyalties are. You must ask people. And we don't ask. When we don't ask, you commonly end up in a situation where the care you are delivering is completely out of alignment with the goals and priorities that a person has in their life. And when that happens, that's when you get suffering. That's when you get an 85-year-old hoarding cookies. So what I started asking, which I don't write about in the book, the connection to the talk this morning, I'd meet these folks who are really good at this, and I'd say, what should be my checklist next week when I next have my conversation with a patient where we're discussing surgery for a problem that I may not be able to fix? What should I be doing differently? And their short answer was, it started with, you should stop talking so much. You should be talking less than 50% of the time in these conversations. They should be telling you what matters to them most. And I paid attention in my clinic, and I found I was talking more than 90% of the time, to my horror. Because my model of thinking was that my job as a clinician was to give people the facts, and that they would then tell me what their answer is. I'd give them option A and option B and option C, and here are the pros and here are the cons and here are the risks and here are the benefits, and now what do you want? But what they pointed out is that instead we have to graduate to an idea of the clinician as counselor. You have to talk about the options and the situation and the facts. But you also have to ask people what are their goals and priorities so you can match what you can offer to what they need and make a recommendation. And there were a few basic questions that we could ask. Those basic questions are ones like, what is your understanding of where you are with your health or your illness at this time? What are your fears and worries for the future? What are your goals or priorities if time becomes short? What are you willing to sacrifice? And what are you not willing to sacrifice in the course of your care for the sake of more time? Does your family know the answers to these questions? Not everyone can answer those questions, but I decided to ask them of Peg, having learned now about trying these ideas. So I asked her, I said, what is your understanding of where you are with your health, your illness at this time? And she said, flat out, I'm going to die. There's nothing more they can do. And she was angry about it. Later, Martin, her husband, told me that was the first time she'd heard her say that she knew she was going to die. And it was a kind of relief for both of them that they could talk about it. They could say it. She didn't have hope around it exactly. I went to the next question. What are your goals then, if time is short? And she said, I don't have any goals that I can think of. The palliative care doctor who gave me these questions did not tell me what to do about that one. So I just went to the next question. I said, well then, what are your fears and worries for the future? And she said, I fear facing more pain. She had a litany. She had an answer to this one. I fear facing more pain. I fear suffering the humiliation of losing more of my bodily control. I fear just dying in this hospital, never seeing anybody again. I've been here for days, and I'm just getting worse. I don't see a way out. That is my fear. And I realized she was telling me what her priorities were in that. So the team may not be able to offer her survival, but it could offer her ways out of those fears. When I went on rounds with a hospice nurse, and it was a complete revelation to me. Visiting a time with a hospice nurse, I thought they were these black hooded nurses who would come with an IV morphine drip ready to send you to the great beyond. And instead, it was this blue-eyed, black-haired former ICU nurse who would go around and visit people, and she would do stuff. Like we came across a woman in congestive heart failure who was having increasing trouble breathing, and she arranged for a nebulizer and for a delivery of oxygen to the home and to make sure her prescriptions were filled. And I walked out the door after and I said, what are you doing? I thought you were supposed to let nature take its course. And she said, my job's not to let nature take its course. My job is to do a different job than medicine usually does. Medicine sacrifices your time now for the sake of possible time later. But when possible time later gets less and less likely, my job is to use our medical capability to give you your best possible day today, regardless of the consequences for the future. give you a good day today. And the fascinating thing is all of the studies show that that actually improves people's well-being, does not shorten their life. On average, it increases people's lives and survival. And so I said to Peg, I said, I visited with this hospice nurse, and this is what she told me. She said that, her aim was, in the best of all worlds, hospice would be making your best possible day today possible, at least under the circumstances. I said, it seemed like a while since you'd had a good day. And she said, it's been a very long while. I said, could that be something we could try for? Just a good day. And that she wanted to try. So a couple days later, she went home on hospice with a hope for one good day. When I got home, I broke the news to my daughter, Hunter, that she would no longer be having any piano lessons. And I debated exactly how to explain it, but I didn't want Peg just disappearing and not having a good explanation. And so I said it was because Peg was dying. And Hunter was struck incredibly low. It was likely, I said, that she'd never get to see her again. She wanted to see her, but I said it's not going to likely happen. But then a few days later, we got a surprising phone call, and it was Peg. And she said that if my wife and I were willing and Hunter wanted to do it, she'd like to resume teaching her piano lessons on hospice. That never occurred to us as having been remotely a possibility. But then I met the hospice nurse, and she explained what she did. She came to her home the day she got home and talked to Peg about what she cared about most in her life, and then she worked to make it happen. And the first goals were simply just get her daily difficulties under control. So they brought a hospital bed, put it in our first floor of her home. They put a portable commode next to it. They made arrangements for how she could bathe, how she could be dressed. They worked on her pain control. The physician on the hospice team massively increased the morphine doses that she got, gave her an extra drug, gabapentin, and then gave her Ritalin, methylphenidate, to combat the stupor that came from the medications. And the result was that her anxieties plunged as all these challenges came under control. Her husband said that she became focused on the main chance. She came to a clear view of how she wanted to live the rest of her days. She was going to be home, and she was going to teach. Now, that took planning and great medical expertise to make each lesson possible. They had to learn to calibrate the meds, for example. The trick was to give her enough morphine that it would hit during the time of the lesson, but not so much that she'd be in a stupor talking to the students and freaking them out. And it worked. Her husband said that she was more alive running up to a lesson and for the days after than he'd seen her in weeks. She'd had no children. Her students filled that place for her. And she still had some things she wanted them to know before she went. She wanted to say her goodbyes, give her parting advice. They were her loyalties. And medicine, I think, has forgotten how vital such matters are to people as they approach life's end, as they try to bring an ending to their story. They want to share memories. They want to pass on wisdoms and keepsakes, connect with loved ones, make some last contributions to the world. And that role, observers argue, is among life's most important. It's how life achieves meaning. And the way we in medicine tend to deny people these moments out of mostly our ignorance, sometimes our neglect, I think is cause for our terrible shame. Peg, however, got to fulfill her final role. She lived 6 full weeks on hospice. Hunter, my daughter, got to have lessons with her for 4 of them. And then there were 2 final concerts. One, a recital with Peg's current students, elementary school to high school age kids. And then the other were all former students, accomplished performers from all over the world. They gathered in a room. They played Brahms, Dvorak, Chopin, and Beethoven to their adored teacher. And then a week later, she fell into delirium and then died peacefully in her bed. I have a couple of remembrances of Peg. One is of her here on her porch a lovely, vital person. And then the second remembrance is from her final recital a few weeks before her death with her current students, including my daughter. And this is when the recital had just finished. Afterwards, she took each child off to the side, off from the crowd, to give them each a personal gift and a few words. And when my daughter's turn came, she gave her a collection of music in a book that she wanted her to learn and to keep. And then she gave her one more gift. "You're special," she whispered to her. And that was something she never wanted the kids to forget. Now, we've made, I think, a 50-year experiment with medicalizing mortality, treating it as just another problem to try to treat or cure. In 1950, the majority of us died in our homes. We did not turn to medicine. That was back when, on that other graph I showed, healthcare was cheap but ineffective. We didn't see why it was worthwhile going to the hospital. By 1990, it was remarkably different. In the US, it was 85% of us died in institutions, predominantly the hospital and secondly in nursing homes and care homes. And talking to people ahead of time here, it seems about the same here in New Zealand. Might be around 15 or 20% who turn to hospice, and not very often hospice in the home. What we recognize is that disease-directed care, which is mostly what we produce in medicine, focused on whatever happens to the disease, is remarkably less effective than goal-directed care, care focused on the goals and priorities that patients articulate. When we provide the goal-directed care, we now have multiple studies, including a randomized trial at the Mass General with end-stage lung cancer patients who lived on average only 11 months. But early palliative care conversations, identifying what people's goals and priorities were, led that group who were in the intervention arm. The control arm had usual oncology care. The intervention arm, with those conversations, they tended to stop by their own choice chemotherapy sooner. They were less likely to go on to the third or the fourth round of treatment. They were less likely to die in the hospital. They spent a third fewer days in the hospital. That overall one-third less costs. They started hospice sooner. They had less suffering at the end of life. And here was the kicker. They lived 25% longer. Because that fourth round of chemotherapy, that last-ditch operation, is mostly a false hope, adding toxicity but little benefit. And so being able to have people articulate their goals and priorities and then discuss making our care deliver on that, that is the opportunity we have in front of us. That 50-year experiment with medicalizing mortality, making it a disease-focused approach, has failed. But I don't think it has to. And we're learning that just a few basic questions, a conversation, can make that turn around. I wanted to add a further part which I don't talk about at all in the book, which is how do we make it work? And we're in the midst of an experiment in Boston with trying to learn how to do that. We've distilled the kinds of lessons down to 7 questions, a 7-question guide that we're training physicians and nurse practitioners and physician assistants in how to use, asking just the questions that I mentioned. It's combined with identifying in the system who the highest risk people are for dying. The most effective, powerful question to ask is to ask clinicians, would you be surprised if this person would die in the next year? And if you would not be surprised, then you should be having a conversation. Fewer than a third have a conversation about their goals and wishes for the end of their life. And on average, it's only at about 30 days, which is very late to have been having it. So we have gone through and created a system to ask the clinicians about their list of patients in clinic. The palliative care teams don't just see their consultation patients, but think about all of those patients who are at risk of dying in the next year. And they will ask the clinicians if they've yet had a conversation with the patient. It's a simple email trigger. If we identify the patient, they send an email. Usually within 2 emails, 90% of the clinicians will have the conversation. We find we're at about 92%, up from 30%, having the conversation, and that it's occurring at about 4 to 5 months ahead of when they die. And we've published some results from small numbers. We still are waiting until we accumulate another year of data. But what we're seeing is that rates of depression, rates of anxiety are at least not going up, which is the accusation of death panels. You have these conversations and you're going to be, making people lose hope and become more depressed. We're in fact seeing reductions in anxiety and waiting to see the depression is at least holding steady, if not going down. When I think about what is possible in a country like New Zealand, where in America we're still battling over whether this is a death panel, what I'm suggesting, where it remains politically extremely controversial about whether we can go out and talk about these things. Here in New Zealand, I think there's much more understanding and willingness to recognize that these are conversations worth having and can be made a normal part of what happens when you enter a care home or have certain conditions that make no one surprised if you might die in the next year. The hard part I see here, and I think this is where further discussion is possible, is that ironically in the United States, we provide full coverage for hospice care. And in the last 5 years, we've seen a dramatic transformation. We went from less than 20% being in hospice care at the end of life to this year reaching almost 50% of our population in hospice care. Here in New Zealand, I think it's probably under 20% from what I understand. And reaching the point that we can make the conversations happen, but then a system be available to people to actualize that ability. Because in the end, all you're doing is trying to show the imagination that a good life is in fact possible for people all the way to their very end. Thank you.